Good day, everyone. Thank you for joining us today for this virtual presentation of the 2020 Cleveland Society of Obstetricians and Gynecologists Research Day program. My name is Jenna Rehmer. I am a second-year Reproductive Endocrinology and Infertility Fellow at the Cleveland Clinic. Today, I have the pleasure of sharing our research evaluating the effects of oocyte cohort size and maturity and antagonist IVF cycles on fertilization, cleavage, blastulation, and high-quality embryo formation. I have no disclosures related to this presentation or my research work. In vitro fertilization, referred to as IVF, has captured the attention of the public since its sensational introduction following the birth of the first test tube baby, Louise Brown, in 1978. This birth was the culmination of decades of scientific research in reproductive medicine. In the early years of IVF, it was performed using a woman's natural cycle. There was a very low oocyte retrieval rate of less than 1 egg per cycle and only a 6% pregnancy rate. Since then, there has been a constant forward momentum improving IVF success rates. Methods have advanced dramatically, starting with the use of gonadotropins to improve oocyte yield to 2.6 oocytes per retrieval and pregnancy rates to as high as 30% by 1983. Increasing doses of gonadotropins led to higher oocyte yield as the years progressed. Following this, there was addition of GnRH antagonists to decrease the premature ovulation rate, oocyte donation for those with premature ovarian insufficiency, and sperm donation for severe male factor. Embryo cryopreservation came on the scene and allowed for storage and use of surplus embryos for subsequent transfers. Improvements in embryo culture and intracytoplasmic sperm injections have also been heralded as steps towards improved success rates. Currently, most IVF labs average greater than 50% success rate for women less than 35. Our own embryology lab here at the Cleveland Clinic had a 69% live birth rate for women less than 35 in 2018. Improving embryo quality has been associated with higher pregnancy outcomes. A high-quality embryo is one that exhibits blastocyst stage by day 5 or 6, has a complete trophectoderm, and tightly packed cluster of inner cell mass. These are the creme de la creme of embryos. These blastocysts possess high success rates for implantation, ongoing pregnancy rate, and live birth rates. There are known predictors of high-quality blastocyst formation such as age, AMH levels, medical background, parity, and BMI. Knowing predictors of high-quality blastocyst formation during IVF is helpful for clinicians to individualize treatment plans and improve patient counseling. Prior studies have demonstrated that low oocyte maturity is associated with incomplete cytoplasmic maturation. Oocyte maturity rate is defined as the percentage of mature oocytes from absolute number of oocytes retrieved following an IVF stimulation cycle. Only mature oocytes can undergo fertilization. Naturally, one would assume the greater number of mature oocytes, the higher number of high-quality blastocysts that are formed. However, our center's quality improvement optimization process on many occasions anecdotally noted that increasingly large oocyte cohort size was associated with a lower oocyte maturity rate. This observation led us to ask the question, does oocyte cohort size affect oocyte maturity and high-quality blastocyst formation? Our aim was to assess if the number of oocytes retrieved, in other words, the cohort size, and oocyte maturity rates affected the following embryo outcomes: fertilization, cleavage, blastulation, and high-quality blastocyst formation rates. This was a single-center retrospective study involving 240 infertile women undergoing antagonist protocol IVF with a total of 261 completed oocyte retrievals performed between January 1, 2018 and December 31, 2018. Various predictive factors of high-quality blastocyst formation have been reported in the literature. For this study, we collected the following data to assess for differences between cohort demographics and outcomes: age, BMI, baseline AMH level, TSH, total FSH stimulation dose, use of HCG during stimulation, trigger drug used, estrogen level on day of ovulation trigger, number and size of follicles, number of oocytes retrieved, number of mature oocytes, fertilization rate, cleavage rate, blastulation rate, and rate of high-quality blastocysts. For fertilization and cleavage rates, the denominator was total oocytes retrieved. For blastulation and high-quality blastocyst rates, the denominator was total fertilized. Utilizing total fertilized as our denominator eliminated poor fertilization secondary to low oocyte maturity as a possible confounder for blastulation and high-quality blastulation rates. Prior literature has shown that live birth rates per transfer improved as oocyte cohorts increased up to 15 oocytes and decreased in cohorts with less than 10 oocytes. Based upon this data, we divided our patients into 3 cohorts, grouped by number of oocytes retrieved. Group 1 with less than 10 oocytes, Group 2 with 10 to 15 oocytes, and Group 3 with greater than 15 oocytes. The following are our results. There were significant differences between the 3 groups with relation to age at retrieval, baseline AMH, estrogen level day of retrieval, trigger drug administered, and total FSH stimulation dose. All of these differences were anticipated and reflect known variances in IVF stimulation across the ovarian reserve spectrum. With regards to cohort maturity, Group 3 had significantly less mature oocytes with median rate of 74% mature when compared to Group 2 with a median rate of 81% of oocytes being mature. When comparing fertilization rate, cleavage rate, and blastulation rate, there was no difference noted between the 3 groups. There was significant difference in the formation of high-quality blastocysts between Group 1 and Group 3, with a median rate of 63% and 53% respectively. Group 2 formed high-quality blastocysts 62% of the time, similar to Group 1. However, this was not statistically different from Group 3, likely due to population size. In conclusion, data from our center suggest cohorts with greater than 15 oocytes have reduced oocyte maturity. This marker for reduced cytoplasmic maturity is manifesting in a 9 to 10% lower median rate of high-quality blastocyst formation. Interestingly, the fertilization rate, cleavage rate, and blastulation rate are unaltered in these oocytes. Additionally, our data offers reassurance to women who have lower than average oocyte cohort recruitment. While total oocyte yield is suboptimal, the rate of high-quality blastocyst formation remains high with a median rate of 63%. Additional studies on the implantation potential, ongoing pregnancy rate, and live birth rates are needed to understand if oocyte cohort size and oocyte maturity have additional downstream effects aside from high-quality blastocyst formation. Thank you for the opportunity to present my research today and for your time critiquing it.